Okay, thanks very much, Remo. Thank you particularly for putting up that little flowchart, which I almost put up, I almost included that myself, because basically pretty much all roads lead to surgery if you've got a stricture. And I'm going to explain over the next 10 minutes or so why I think that in fact early surgical intervention in Crohn's disease-related ileal strictures is probably the right way forward. There are my disclosures again. So some disclosures in addition to the usual ones. First of all, I'm a physician, not a surgeon. You definitely wouldn't want me operating on you. And of course, I do use medical therapy in all sorts of patients, including patients with stricturing disease. But of course, I am part of a multidisciplinary team, and this is how stricturing disease ought to be managed, because of course, it is not simply a physician's or a surgeon's decision, but one to be taken by a team. So what is a stricture? And here is a picture that we both put up. And of course, a stricture is a narrowing within the bowel, which is nearly always accompanied by pre-stenotic dilatation. And pre-stenotic dilatation is, depending on which modality you use, is generally thought of as about 3 centimetres if you're using CT or MRI, where you've got intraluminal contrast. There's 1.5 times normal diameter on MRI, and normal diameter on MRI of the ileum is about 2 centimetres. That comes about 3 centimetres as well. So now we know what a stricture is. I'm going to give you 10 reasons why I think early surgery is better. So reason 1 is that there's very little evidence actually to support drug therapy. And that's partly because, of course, all the trials that are done in patients with Crohn's disease tend to include the presence of strictures as an exclusion criterion. So all of those patients that we're quoting the effect of medication in, of course, have been excluded if they've got stricturing disease. So we have to be very careful about extrapolating the effect of drugs into that patient cohort. The second reason is because the evidence that there is not very convincing. And both Remo and I recognise that the Creole study that Jeroen Bunik published, and which Remo showed you a few moments ago, is probably one of the better studies out there. And as Remo said, it's a study in which adalimumab was given for patients with stricturing Crohn's disease, and I've put stricture in inverted commas here because, of course, this was a carefully selected population. And in fact, the actual mean pre-stenotic luminal diameter on MRI was only 25 millimeters, so not even really for most of the patients reaching a level of pre-stenotic dilatation of any significance at all. Remo outlined what the definition of success was at 24 weeks. That is no use of prohibited treatments, no endoscopic dilatation, no surgery, and being able to stay on the drug. Note, success was not defined by symptoms, and of course that's one of the big problems with stricturing disease. It's not very nice. It causes pain. People can't eat the foods they want to eat, and they go onto very restricted diets. And I would argue that even though there was some success in this study in people avoiding surgery effectively, I'm not convinced that it creates a particularly great quality of life. And in fact, the biggest factor associated with success was not really having pre-stenotic dilatation. So if you didn't have pre-stenotic dilatation, you were more likely to succeed. And again, really what that is telling us is people who don't have much in the way of stricturing are the ones who are going to respond. And if you look at the original cohort of 93 patients, by 4 years, 70% of them had an operation. So in fact, I think it's really evidence that we're just delaying the inevitable. I think another problem with medical therapy in stricturing Crohn's disease is it's very difficult to know if it's the drug that's being ineffective, because there's no defined way to measure response, although Florian Riedler and colleagues are working hard on this at the moment. But imagine you're in the scenario where you have your patient with a stricturing Crohn's disease. Often they don't particularly have much in the way of biomarkers of disease activity. You give them the drug and they don't get any better. Is the problem that the drug doesn't work, or is the problem that, of course, the drug could never work because of the disease? And the real issue there is that once we consign a drug to the bucket of this drug doesn't work, we rarely go back to it. And so one can cycle through drugs in this scenario and effectively waste them for the future and avoid surgery in a way that is inappropriate. And indeed, for most of these people, I think we're simply delaying the inevitable. Reason 4 is because, and Remo again has mentioned this, is that it's actually quite difficult to know whether strictures are inflammatory or fibrotic. Even with advanced ultrasound techniques, which I think carry probably the most promise at the moment, the sensitivity and specificities are somewhat variable. And indeed, if we look at the excellent review in Gut, then in fact the conclusion in the abstract was that although there are cross-sectional imaging techniques that can be used in this scenario, they are not sufficiently accurate for use in routine clinical practice. And that's the problem here. Even though we know that most strictures have a combination of inflammation and fibrosis, we're still very bad at knowing which is which. And again, I think that leads to inappropriate medical therapy at times. Reason number 5, let's not forget drugs have risks too. I've cherry-picked an early study here of infliximab. This was when Jean-Fred Colombel was doing his sabbatical at the Mayo Clinic and described their early experience of treating 500 patients with infliximab. Note just a median of 3 infusions. It's not really even maintenance therapy. Follow-up for about a year and a half. And you can see all the side effects that we tend to see in patients, acute infusion reactions, serum sickness, drug-induced lupus, even a demyelination in there in those early days. Most importantly, though, nearly 10% got infections attributed to infliximab. 20 patients had serious infections, 2 of whom had fatal sepsis, 2 of whom died from pneumonia. And indeed, in the overall cohort, there were 10 deaths, 5 of which were possibly related to infliximab. Of course, we know how to use drugs and we can use them safely, but we mustn't think that they are risk-free. There's another reason why we shouldn't delay surgery in stricturing disease, and that's because if you leave stricturing disease, it can become penetrating disease. And of course, that's a bad thing to happen. It's associated with worse outcomes. It's associated with an increased need for stomas and things like that. And this is just a study looking at what happens with the natural history of stricturing disease. And if you look at these people here, these are the stricturing patients who progress to penetrating disease. So if you leave that sort of phenotype alone, you'll simply create problems for the future. And then, of course, sometimes there are nasty things hiding in strictures. This was a case report that I found earlier today, looking at a fairly standard patient just with 3 terminal ileal skip lesions with pre-stenotic dilatation, went for surgery, and what did they find? Adenocarcinoma. You would never have guessed that from the MRI. There were no clues, but sadly, even though it's rare, a proportion of patients with stricturing disease are harboring carcinomas in there. Reason number 8, surgery is actually quite a good treatment for Crohn's disease. This isn't even stricturing disease, this is inflammatory disease. And this is the LYRIC study from Willem Bemmelman and colleagues in Amsterdam. And the primary endpoint here was quality of life. And what became apparent is that if you follow these patients out for a year who were randomized with their terminal ileal Crohn's disease, either to receive infliximab or to have a limited terminal ileal resection, then whilst you get a drop in quality of life in the surgical cohort immediately after surgery, as you would expect, because they've just had an operation, as you head out to a year, their quality of life starts to beat that of the patients on infliximab. Not only, therefore, is surgery a good short-term treatment, but it's actually quite a good long-term treatment, at least in some patients. And those are the patients who are effectively almost cured by Crohn's disease. And this does happen with patients. And again, if we look at the long-term outcome of the LYRIC patients, the patients who were randomized to resection, that's this group over here, you can see that about half of them at 5 years are still on no IBD treatment at all, or only on an immunomodulator. So they do very well post-operatively. Interestingly, of course, if you look at the patients who've been treated with infliximab, then you will see that about half of them have ended up with surgery by this time anyway. Again, you're simply delaying the inevitable. And then finally, of course, I think the other reason why surgery is good, because we're very good now at preventing Crohn's disease from coming back, much better than we were. So I've just said that a significant proportion of people will do very well with Crohn's disease surgery in the long term, and you can make even more of them do well by treating them effectively post-operatively rather than ineffectively pre-operatively. And again, I've just picked out Miguel Reguero's original study here of using infliximab in the post-operative setting, and you can see that these patients were randomized to receive either infliximab or placebo, having had an ileocecal resection, and you can see that the infliximab-treated patients, 91% of them were in endoscopic remission at a year, and the non-infliximab-treated patients, 85% of them had recurrence. So if we use the right treatment post-operatively, having done an effective form of therapy, that is an operation, then we have good long-term outcomes. So I'm going to conclude there. I've given you 10 clear reasons why surgery is the right option in stricturing ileal Crohn's disease. Early surgery makes sense to me, and I ask you, why on earth would you leave people with symptoms when you can make them better and keep them better with appropriate surgery and post-operative medical therapy? Thank you.